Good afternoon. I'm David Van Slyke, Dean of the Maxwell School of Citizenship and Public Affairs, and it is my pleasure to welcome you to the 32nd Annual Herbert Lourie Memorial Lecture on Health Policy. I would like to acknowledge with respect the Onondaga Nation, the firekeepers of the Haudenosaunee, the indigenous people on whose ancestral lands Syracuse University now stands. The Lourie Lecture is held in honor of Dr. Herbert Lourie, who is a distinguished physician and a member of the national and international medical communities in the field of neurosurgery. Dr. Lourie was a physician who understood medicine as a high calling that demands the utmost of skill, intellect, compassion, and character. This lecture series is a wonderful opportunity to bring our community together with a distinguished and thoughtful individual who is involved in the issues that animated Dr. Lourie's life. I would like to welcome several members of the Lourie family who are in attendance at today's lecture. Dr. Gerald Lourie, Miss Suzanne Lourie, and Carol and Daniel Blanchard. I would also like to thank the Central New York Community Foundation for their generous funding gifts that make this lecture series possible, and the Lourie family for their abundant support throughout the years. I thank the Center for Policy Research and its director, Dr. Leonard Lopo, and the Lerner Center for Public Health Promotion for hosting the annual Lourie Lecture. CPR is home to nationally and internationally recognized scholars who conduct a broad range of interdisciplinary research and other activities related to public policy. It houses the Lerner Center for Public Health Promotion, which Dr. Shannon Monick directs. Today's topic is particularly appropriate. As all of us are aware, in recent months, the COVID-19 pandemic has shaken the lives of so many people, including our acquaintances, close friends, and family members. Today, we will hear from an internationally recognized expert, Dr. Sandro Galea, about his research related to inequities in the impacts of COVID-19 across different demographic and social groups, and potential approaches to mitigating these and other population health inequities. I would now like to introduce to you the Lerner Chair for Public Health Promotion, Professor Shannon Monick, who will then introduce our 2020 Lourie Lecturer, Dr. Sandro Galea. In addition to her role with the Lerner Center, Shannon is an associate professor of sociology in the Maxwell School and the co-director of the Policy, Place, and Population Health Lab as part of the Aging Studies Institute. Shannon is an active researcher, dynamic teacher, and a tremendous citizen of the Maxwell School and Syracuse University. Her leadership has been instrumental in placing the Lerner Center at the forefront of research centers focused on health promotion, and she has attracted a growing and enthusiastic following. Please join me in welcoming Professor Shannon Monick.
Thank you, Dave, for that wonderful introduction. Before I introduce this year's Lourie Lecturer, I'd just like to tell you a little bit about the Lerner Center. The Lerner Center is a population health research center based in the Maxwell School. The center was established in 2011 with a gift from Sid and Helene Lerner. Our mission is to improve population health through applied research, education, and advocating for evidence-based policy and practice change. We have a public health research brief series that summarizes recent findings from faculty and graduate student researchers on a wide variety of pressing population health topics, including the opioid crisis, racial and ethnic and geographic health disparities, and COVID-19. We've provided a link to the series in the chat box, and I encourage you to check it out. We are pleased to co-sponsor the Lourie Lecture with the Center for Policy Research. I'd like to thank the CPR staff, particularly Laura Walsh, for all of the time and effort she put into organizing this year's Lourie Lecture. There will be time for Q&A at the end of the presentation, so please add your questions to the chat box. This year's Lourie Lecturer is Dr. Sandro Galea. Dr. Galea is Dean and Robert A. Knox Professor at Boston University School of Public Health. He previously held academic and leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. Dr. Galea holds a medical degree from the University of Toronto, graduate degrees from Harvard University and Columbia University, and an honorary doctorate from the University of Glasgow. His research addresses a wide array of population health topics on the social causes of multiple physical and mental health outcomes, including trauma, social isolation, racism, climate change and natural disasters, the mental health effects of 9/11, firearms, opioids and other drug use disorders, the role of corporations in population health, and the role of the healthcare system in addressing the social determinants of health, just to name a few. He has already published several articles related to COVID-19. PubMed shows that he has over 800 peer-reviewed journal articles. His work has been cited over 65,000 times, making him among the most widely cited scholars in the social sciences, population health sciences, and public health. He's also a regular contributor to a range of public media. Dr. Galea is an elected member of the National Academy of Medicine, chair of the board of the Association of Schools and Programs of Public Health, and past president of the Society for Epidemiologic Research and the Interdisciplinary Association for Population Health Science. He has received several Lifetime Achievement Awards. In his most recent book titled, Well, What We Need to Talk About When We Talk About Health, Dr. Galea argues that our challenge is that we are not really investing in health. We're investing in healthcare. Doctors and medicine make all of the difference when we're sick, but they do not determine whether or not we get sick to begin with. Our health is shaped by our shared contexts, the social, economic, and environmental conditions in which we live. He suggests that we should think of these contexts like water in a goldfish bowl. Just as a goldfish cannot have a healthy life if it lives in dirty water, we can't be healthy if our context is not conducive to a safe, disease-free existence. Unsafe neighborhoods, low-quality schools, an unjust, unequal economy, and racism, just to name a few, are examples of the dirty water that undermines health. And now, without further ado, I'm pleased to introduce Dr. Sandro Galea as the 32nd Annual Herbert Lourie Memorial Lecturer on Health Policy.
Thank you very much. Thank you, Dean Van Slyke, and thank you, Professor Monat. It's really an honor to be here, really an honor to do the Lourie Lecture. Professor Monat reached out about this a long time ago, and I was actually looking forward to visiting in person to do this lecture. And I was disappointed, as with many other things in the COVID era, that I would not be able to be there in person. But please know that I am there with you in person, at least in spirit. And I was glad that we could still do the lecture despite the fact that we are now doing things digitally. I'm going to share my screen. So after that very kind introduction, I realize it's all downhill from here, so please bear with me. But my goal is to talk about something which has animated a lot of my thinking and a lot of my writing in the past, really in the past decade. And it is how our health is fundamentally socially patterned, that our health reflects the world around us. And this has been true really for decades and decades in this country, and one can also make this argument globally. I'm going to talk nationally for today's talk. And the COVID-19 time hasn't really done anything different. It hasn't shown us anything different. It simply has revealed what was already there before. So I'm going to talk about this topic, health haves and health have-nots in a time of COVID-19. As you're going to see, most of my talk will be health haves, health have-nots in general, but then I'm going to show how COVID-19 has made this ever more apparent. So let me start. The first point is we need to understand health. Now, I appreciate that everybody here who has signed up for this lecture came for a health policy lecture. So I understand that the impulse may be say, no, I get health. And we all do. So please bear with me. All I want to do is put health in context, is help us all understand health in context in a way that I think seldom represents how we think about health, and in a way that really stops us as a country from achieving what we should achieve on health. And I start by telling a story. Some of you who've been to my previous talks may have heard me tell the story, but it's a story of Blind Willie Johnson. Blind Willie Johnson is he's a blues man. Those who like the blues will recognize Blind Willie Johnson, part of the canon of blues greats. We have a few of his songs left. And Blind Willie Johnson was born in Texas around the turn of the 20th century. He was born sighted. And the story is that when he was a young child, he lost his vision in a domestic violence incident. And so he grew up poor and blind and black in Texas in the early 1900s. He got married and him and his wife were living in a small house which burned down, but they didn't have any money to move, so they actually kept living in the burnt down shell of the house. When he was in his 40s, in the 1940s, Blind Willie Johnson developed malaria. Now, this is Texas in the 1940s. Malaria was actually fairly common. Those of you who know the history of the CDC, for example, will remember that the CDC initially was started as a center for control of malaria. Malaria was a big problem in this country. So in some respects, there was nothing particularly dramatically unusual about Blind Willie Johnson getting malaria. And his wife took him to hospital, and he was turned away from hospital. And it's not clear if he was turned away because he was poor, because he was black, or because he was blind. And then Blind Willie Johnson died. Now, the question is, why did Blind Willie Johnson die? There's only one answer to that question, which is malaria. He died of malaria. It was, had he received treatment, had received chloroquine, lately much in the news, for his malaria, he actually would not have died at that moment. But the reason I tell that story is because I think anybody who's paying attention will recognize that, yes, he died of malaria, but it wasn't just malaria that killed Blind Willie Johnson. It was also poverty. It was also racism. It was domestic violence. It was homelessness. It was poor access to care. All of these factors contributed to his death. And all of those factors would have made him die of something else soon, even had he not died of malaria. Now, why is this important? It's important because it makes the very simple point that health is not just malaria. Health is malaria, yes, but also all these other factors. And once you understand that point, everything else falls from that. Now, I suspect that most people on this call are saying, yeah, that's obvious. I know that. And I would challenge us to say, well, if we know that, and if it's obvious to us, and presumably it's obvious to people of sound mind who think about it, why is it that we do not behave like that? Now, what do I mean we do not behave like that? Well, we know, this I'm now just taking Blind Willie Johnson, showing it graphically. Health is caused, yes, by medicine, healthcare, which is down here, maybe 10%, maybe 20%, but by our behaviors, by our physical environments, by socioeconomic factors. Again, we know this. This is the Blind Willie Johnson story rendered as an infographic. We know this. But where do we spend our money? I've just taken the infographic on the left, and that's sort of, I've now rendered it into this infographic person. And on the right, I've put in where we spend our money. 90% at least, conservatively, of our money that we spend in health is spent on medicine. In other words, on malaria. We spend far less on behaviors and all the other forces that also affect health. So my challenge to us as an audience is to say, we can't have it both ways. If we know this, why is it that we do not behave accordingly? Well, if we don't know this, then we need to make sure that the world knows this. So this is the conundrum we're in, that in the world of express preference and revealed preference, and maybe our express preference to say, we know this, we get the story, yeah, don't bore us with the story. But our revealed preference is that's not what we spend our money on. We spend our money on malaria. It is as though the racism, the homelessness, the domestic violence, the poverty that affected Blind Willie Johnson fundamentally are not what health is about. And we put all our money in malaria. And we put a lot of money in malaria. Now, obviously, I'm using malaria as a metaphor, so please don't misunderstand me. I'm talking about malaria as in healthcare and medicine. This is the US. This is our spending on health, which is largely healthcare. This is all the other rational high-income countries. They also spend more, but they spend about 40% less than we do in terms of the money that we spend on healthcare. So we spend a lot of money on the malaria end of things. And as we are doing that, we are spending less and less on other things. This is from the Congressional Budget Office, the CBO. This is our Social Security spending. This is our healthcare program spending increasing. This is all other spending, which broadly speaking has been decreasing ever more. So if we get the Blind Willie Johnson story, if we get that story, somehow that's not translating into our policy. Because if we get it, we are acting completely inconsistently with the story. We are spending more and more on treating malaria and spending less and less on everything else, which fundamentally is probably the majority of the cause for health. Now, I live in Massachusetts, which, and you'll live in New York. These are sort of two of the most progressive states in the country. Massachusetts is almost like in Canada. But I want to show you spending in Massachusetts. This is a 15-year spending in Massachusetts. Increase in spending of healthcare. Actually, I can't read the percentage because the Zoom is covering it, but you all can. Some increase in transportation, some on housing, less on housing that's not emergency assistance, a little bit on primary secondary education, less or the same on public safety, less on mental health, less on education, less on early childhood education, less on public health, less on environment and recreation. I don't know what the New York data are, but I'm sure you could all look at that. Now, this is Massachusetts. This is one of the most progressive states in the country. And even in Massachusetts, we are essentially working backwards if we are to implement an agenda of promoting health, because we are simply spending all our money on malaria and ignoring all the other factors that also shape health. Now, what's been the result of that? Well, the result of that has been, in many respects, catastrophic for the nation's health. Notice I haven't even started discussing COVID, and then we're going to talk really about catastrophe, but I haven't even talked about COVID yet. I'm simply pointing out that we as a country have allowed our life expectancy to fall off the trend for all the other same rational high-income countries, which I showed you earlier, which, by the way, remember, spend a lot less on health than we do. So remember, they spend less, they get more. Over the past 3 years, although there's been an exception this year before COVID, although it's going to change, we've had a 3-year, year-on-year drop in life expectancy. And fundamentally, we have about a 5-year gap in life expectancy between us and the highest achieving other high-income countries. That means, I can say 5-year less in life expectancy, and that sounds clinical. So let's say it in a way that perhaps sounds more as a more emotional tug, that we, all of us on this call, have chosen to die 5 years sooner than other countries, despite the fact that we're paying much more. Now, you may be thinking, well, I didn't choose it, but you did. I mean, we collectively are choosing this. We are choosing to die 5 years sooner. And I would ask you to, if I were in person, I would ask you to raise your hand. It's a bit more awkward in Zoom. How many of you really want that? How many of you really want to choose to live 5 years less? But that is fundamentally what we are choosing as a country. And it's because we as a country underinvest in the forces that shape health. We underinvest in education. We underinvest in nutrition. We underinvest in parks and opportunities for recreation. We underinvest in creating opportunities for livable wages, for stable wages. And this becomes a real issue when talking about COVID. We underinvest in housing, in opportunities for housing. And we underinvest in opportunities for people to be brought together, not to be isolated, and not to have poor mental health. These are all areas that are contributing to our health, that really shape the life of blind Willie Johnson and of all of us, in which we underinvest because we put all our health money in treating the disease, treating malaria, once it's already started. And that is fundamentally the challenge that this country has faced for the past 30 and 40 years, and one that unless we deal with, we are not going to be improving our health and also the environment. So here's the final picture. On the x-axis, you have our spending. On the y-axis, you have our life expectancy. And what you see is all other rational high-income countries, you spend more. Go back, you spend more, and you get less. You spend more, you get more life expectancy. Not us. We're sort of off the curve. We spend more, and we don't gain more. It's for those of you who do child development, it's a little bit like when you're looking at children growth charts. It's like it's when you say a child is failing to thrive, and the child is falling off the development scale. That's us on health. We are failing to thrive. And that is that's the moment that we were in when we faced COVID. That is the country that we were in when we faced COVID. And that is ultimately what has shaped much of what's happened with COVID in this country. But before we talk about COVID, let's talk about some of these underlying forces. Remember, I started at the beginning by saying that my fundamental premise is that our health is imprinted. Social and economic factors imprint on our health, that they drive our health. So I want to start by talking about some of the social divides that then are imprinting on health divides. And I want to show you these because, to my mind, they are, in the context of thinking about health policy, they are inextricable. We cannot think about health divides. We think about health haves and health have-nots without thinking about social haves and social have-nots. And the picture on haves and have-nots in this country is pretty bad, actually. It's actually a pretty bad picture. We are because we're in a university environment, I think it's probably a fair guess that I'm in an environment of progressive liberal people who think of, we get animated and invested in things like, well, the richest 1%, et cetera, et cetera. But I often feel that those rhetorical devices are not very helpful because they distract us from much more foundational divides between, for example, the richest 20% versus everybody else. So income in this country has essentially risen only in the past 30, 40 years for the richest 20%. The other bottom, the poorest 80%, essentially have had no rise in income. Again, I would normally get you to do a show of hands and ask you how many knew that? How many knew that only the richest 20%, which by the way is essentially everybody on this call, just to be clear about our incomes, has actually risen for the richest 20%, not for the poorest 80%. We actually have a paper that's coming out in JAMA Network in a couple of weeks showing that these 20-80 divide shapes a lot of health divides in the country. So richest 20% is where income are rising. That's income. How about wealth? Wealth is an extraordinary divider in this country, particularly along racial lines. On the left, you have income, white families, black families. On the right, you have wealth, this extraordinary gap in wealth between white families and black families, because of course, wealth depends on accumulation of resources over generations. And when you have black families who haven't had an opportunity for that accumulation, simply going back to deeply rooted forces of structural racism, going back to slavery, which I'll get to in a second, you are inevitably going to have this wealth gap. And of course, that wealth gap then becomes patterned as a health gap. And I would argue that there is an argument then to be made for a health argument for thinking carefully about issues like black reparations to try to remedy these wealth gaps, specifically to narrow health gaps. And of course, black wealth lags at every level. Let's look at this. This is less than high school education. The green is white and the pink is black. This is wealth gap in less than high school education people, high school education, some college, bachelor's degree, advanced degree. That is the wealth gap that we face as a country. And this change in wealth is actually only getting more and more. This is wealth change by race, ethnicity in this country. This is white wealth, this is black wealth, and this is Latinx wealth. So not only do we have these social and economic divides, these social and economic divides have been deepening. Like, isn't that extraordinary when you think about it? Like, if you buy the argument that our health is divided into health haves and health have-nots, and it's patterned by social and economic haves and have-nots, and you understand that we have been misinvesting on the health by investing only in malaria and the healthcare, then on top of that, you say, not only that, we actually are deepening the social and economic divides that create these health divides. I mean, to my mind, it's enough to make you say, why are we doing that? What kind of country are we living in? Like this defies logic, and it defies our expressed preference for health. Now you may say to me, well, we don't have an expressed preference for health. And I would say, can you think of another reason other than our health why we would have upended our whole country, changed everything the way we do, the way we did in 2020? Other than health. Health is why we did it, which means we care about health and we somehow still intersect with it the wrong way. This is a map of slavery. It's a map of slavery in the mid-19th century. And I want to show this because ultimately this sets the stage for deep racial divides that also become health divides. And it's impossible to have this conversation without actually bringing in the foundational causes of the forces of structural racism that really all come from slavery, from hundreds and hundreds of years of that, which of course mirror in things like this. This is deep racial segregation. This is in Detroit. This is around 8 Mile Road. You have the green dots and the blue dots, which are white and black. And what's amazing here is just look at the segregation. Just like you cross a road and it changes color dramatically. That is the kind of country which builds on the legacy of slavery and of segregation that we've had for hundreds of years, that becomes social divides, that ultimately becomes health divides. So social divides and economic divides. Now let's talk about the inevitable health divides that emerge. I put in the word inevitable here as I was preparing this talk because I thought that given this a health policy lecture, by the time I get to this point, you're all going to say, yeah, we get it. We get this is going to become health divides. But work with me. I'm going to show you some of these health divides. So first of all, we can start overall. This is overall looking at black, white life expectancy, and these are adjusted death rates, showing there's about a 4 to 5 year gap overall in life expectancy in black and white. It's much wider when you compare black men in particular, which have lower life expectancy than anybody else. And this is actually a map of this is what I showed you before, slavery in the 1860s. This is just that map rendered GIS. And the reason I'm showing it to you here is because I want to show you how this map looks a lot like that map, which is the density of stroke and the stroke belt in the country. How the map of slavery from hundreds of years ago maps onto a map of health burden today, which just shows really, to my mind, how our social divides, our centuries of creating social and economic divides and creating structural forms of excluding particular groups literally maps onto geographically patterns of poor health burden where we are today. This is looking at black mortality rates, simply just to show you the sort of how this maps on by race, that you have higher mortality rate every age group, which is young age, middle age, older age. In risk factors, black, white, again, young age, middle age, and old age. And I could go on and show you sort of the various patterns. Let's talk about income for a second. This just looks at two cities, New York and Chicago. And what I want to show you here is these are six different disorders. And here you're dealing with the poorest 10% of neighborhoods. Here you're dealing with the richest 10% of neighborhoods. And I'll show you here. So up here you have more health condition. And just look at this. Like, it's extraordinary. Poorer areas, you have more of everything. Richest areas, you have less of everything in terms of health. I'm often asked when I do talks, not to an audience like this, not to sort of to a health savvy audience, but when I'm going to talk to lay audiences, which I do sometimes, one of the first questions is like, so what should I do to make myself healthiest? That's very typically the first question. And there's only one answer to that, which is you should choose to be born to well-educated, well-off majority group parents. I mean, that's really what you should do. And if you can choose that, you're going to be fine. Your health is going to be fine. So that's income. And I want to show you this. I actually quite like this graph because it sort of brings the concept, the intersecting concepts of income and race together. And the way to read this is, these are the same 6 different diseases I showed you before. Let's just focus on the middle panel. It's a complicated graph. It's actually very straightforward when you break it down. We just focus on the middle one, which is asthma. They all behave exactly the same. So these are looking at census tract incomes. So when you go here, you have a richer census tract, and this is prevalence of disease, so asthma. So all I want you to see in this cluster is that there's a best fit line that goes like this, right? The richer the census tract, the less asthma. That's point A. But point B is that the census tracts are shaded with the more purple means the greater the share of the Black population. So what you see is the richer, the less the disease of the 6 diseases. But of course, the Black census tracts are in all of them clustered in the poorer and in the high prevalence area, which of course I think makes the case about the confluence of income and race. And in the scientific literature, we sometimes spend, I think, too much time sort of arguing about, well, is it this or is it that? The truth is, it's very hard to isolate causes with these things because these causes co-occur and they are inextricably wound up in each other. So, the country, what causes health, our social and economic divides, and then how those divides become our health divides. So that is the country that we have built. That's the country that we have built over the past 40 years. And we can talk more about sort of inflection points in the country's history in the question period. And then COVID hit. So now I want to talk about COVID. So I want to bring that and say, that's the country that COVID found. That's the country that SARS-CoV-2, the novel coronavirus, came and found us in the country in that state. So what happened? What did COVID do to us? And how did that then overlay on this, on the presence of these social divides, economic divides, and the consequent health divides? So about COVID, COVID has been bad. It has dominated all our lives. We all know this, about almost 190,000 deaths now in the US. It's all over the country. It's about 6 million cases that we've had. And we can talk more about the COVID pathophysiology, but it's almost beside the point. But this is the epidemic curve. I think I did this at the end of the month a few days ago. So we had a first wave, and then we now have the second wave, which is now sort of going down. That's broadly where we are with COVID, and that's the virus itself. And these are deaths. These are deaths from the virus. The first wave had a lot more deaths. The second wave has had fewer deaths. And that's also at this point going down. We'll see where it goes come the fall. And all of that has led to enormous social transformations. New York City, Times Square, looking desolate. And it really has led to an unprecedented social transformation of any time really in the past 100 years. Because of course, it's not just COVID, it's not just a virus, not just a pandemic. It is also, in no small part, this. This is unemployment, change in employment. This is a dramatic decrease in employment, and which is now beginning to recover. What this graph does not show is that high income employment is recovered to just minus 0.5% today. Low income employment is still 50% off what it was before COVID, which of course means that the economic divides I showed you earlier are now deepening. They are now deepening in time of COVID because, I'll see those numbers again, I'm sorry I don't have them on the slide, that high income employment has essentially recovered. Low income employment is still 50% below what it was in COVID. Now, remember what I was showing you earlier about economic divides, how they become health divides. So it's not a stretch to then say, how is that going to affect our health divides going forward? And just to give a sense about how bad the unemployment was, because, we are all speaking about this from within the university setting, and there's been a lot of challenges in the university setting. I never want to minimize them. I deal with them every day. You deal with them every day. But let's face it, we're actually pretty privileged. We are very lucky compared to the world around us. Just to give you a sense, this is unemployment where it was sort of trucking along and then was sort of this enormous spike. And we all know that. But I just want to take a step out, a lens out, taking out 5 years, and just to show how dramatic the increase in unemployment was around COVID. Like, this is where we're along. And then there's this enormous perturbation. So I feel like for all of us sitting comfortably in our chairs and saying, this is bad, it's actually hard to even wrap our brain around how bad it is. And in the context of health, in the context of a thesis that health divides are patterned by social and economic divides, this is now deepening and deepening, making it worse, making it substantially worse. And I don't think we can have a COVID conversation without having this conversation that I started us off on the underlying health divides that we have in this country. And of course, on top of that has been the civil unrest, the justifiable anger at centuries of structural racism, a lot of it anti-Black racism, that of course then boiled over with the murder of a number of people, all in the same place, with George Floyd and many others. And that reflects an intersection of the moment. It reflects an intersection of the moment. And I would argue it reflects these deep-seated underlying divides, social divides, economic divides, and health divides. And they all came together because of a health condition, because of COVID as a moment of health. So is that true? How has it manifested as COVID and health divides? Because if what I'm saying is true, then we should have seen health divides and COVID, which, by the way, we did see, as I'm going to show you, and which, by the way, those who studied this wrote about in the beginning of March. I mean, I had a piece, Scientific American, beginning of March, saying we are going to see this because it built exactly on the underlying patterns of divides. And that's exactly what has happened. So about Black people are about 13% of the population. They account for about 24% of deaths. Black people are dying about twice the rate of white people. And of course, that reflects both the risk of contracting COVID and then dying from COVID. And I'll get into that in a second. This is the death rate per 100,000 by race ethnicity. You see Black death rate compared to white death rate with American Indian Alaska Native and Latinx death rate right there. But it's a twofold increase in death from among Black versus white. And just to sort of give it some numbers, if they died of COVID at the same actual rate as white Americans, about 20,000 fewer Black people would have died. 8,400 Latinx people, 600 Indigenous people would still be alive. So just to say this again, 20,000 Black Americans died who wouldn't have died if Black death rate was the same rate as white Americans. And we've had all the civil unrest about the police shootings and the deaths from there, but 20,000 deaths is just a lot of people. It's a lot of people that really is fundamentally a social patterning of disease. That's the same social patterning we had pre-COVID, manifesting in a time of COVID. 20,000 Black lives lost that wouldn't have been lost if COVID death was the same rate as white Americans. So that's the country that we had built. COVID didn't do anything special. It simply came in and overlaid on the country that we had already built. And by the way, this has been true everywhere. I just want to show you this. This is DC, Illinois, Michigan, Tennessee, Wisconsin. And in all of these, you can just focus on DC. They all show the same thing. All I want to show you, the blue is the percent of population. The orange is the percent of COVID cases. And the gray is the percent of COVID deaths. So what you see in all of these is this pattern. Black, you have more COVID cases than the population, more COVID deaths than cases. White, you have more population than you have COVID cases than you have COVID deaths. And of course, the reason for that is because the risks for getting COVID and dying from COVID are different risks. As I'm going to show you in a second, the risk of getting COVID fundamentally is influenced by underlying social conditions that make you more likely to be exposed to COVID. Risk of dying from COVID is fundamentally patterned on your underlying conditions that make you more susceptible and vulnerable to adverse consequences once you have COVID. But both those conditions reflect the social and economic reality and the underlying health reality. This is a picture that looks at deaths above normal and overall deaths. This is looking at the sort of over time epidemic peak. That's white, that's black, that's Latinx, and that's Asian. This shows the overall, how every single moment in the pandemic, there's been an extraordinary increase above normal in black mortality in particular. By the way, I do want to comment that I'm talking about race and income in this country. This is a universal pattern. I'm going to show you this data from England, simply actually because this is the best data that's out there. And I quite like this graph, and I think it makes the point very nicely. In England, what you see here is this is the epidemic curve. This is the first wave epidemic curve. And the way to read this is the quintile 5 is the richest 20%, and the quintile 1 is the poorest 20%. And what you see is this beautiful epidemic curve, right, for everybody. But look at this. The richest 20% is always lower at every point than is the poorest 20%. And so this is a pattern that's consistent that the have-nots become the have-nots. And deaths follow the exact same pattern, same thing. Richest 20%, poorest 20%. So the social divides become health divides. They become these health divides in time of COVID. So let's now sort of talk about why this has happened in COVID and how to bring all of these ideas together. So why is it that Black Americans were more likely to get COVID? Forget about dying from COVID first. Well, like to get COVID because the risk factors for getting COVID, which fundamentally is contact with other people, were more prevalent among Black Americans than among white Americans. Why is that? Because, for example, wealthier Americans, and remember this sort of quite a heavy congruence between Black, white, richer, poorer, were less likely to be in jobs that afforded them the luxury of being distant from other people. Here's one very simple graph that shows this. This looks change in movement. Change in movement when things were happening. Remember, first week of March when the whole world seemed to stop. Well, it did seem to stop, but you know what? For those of us in the wealthiest group, it stopped days earlier than for those in the less wealthy group. And those days make a big difference in your risk of contracting COVID, particularly at a time when we didn't know what was going on. And when in New York and Massachusetts, your state and my state where I live, where had such a high probably density of asymptomatic cases, which meant it was very easy to contract COVID. So more money you have, you're able to isolate much faster. And here's another, I'm going back to the UK report just because they have such excellent data on this. Here it just shows you this, just focus on education and earnings. The likelihood that you can work from home, the higher your education, the more likely you are to work from home. The more your earnings, the more likely it is that you can work from home, right? So the forces of social division and economic division that were shaping our health pre-COVID, when COVID hit, they were the same forces that programmed our likelihood of getting COVID. How more education, more income, you're more likely to work from home. How about vulnerability then to COVID and to its effects? This is, this is income decile. The yellow is ever being diagnosed with illness that makes you vulnerable to COVID. And the green is having a long-standing mental health condition, which of course makes you vulnerable to COVID mental health consequences. I'm going to show you in a second. The more money you have, the less likely you have to have an underlying medical condition, which of course makes you then more likely to die from COVID. Because one of the things that we know from COVID is that medical comorbidity, underlying comorbidity, is the central risk factor for having adverse consequences of contracting COVID. Similarly, more money you have, less likely you are to have a mental health condition, which then means you're more likely, you're more likely to have, or less likely to have mental health. And we know that this is the case, and we know this is the case. Here's some data from China, the first data available. Death rate for COVID-19 patients. If you have cardiovascular disease, diabetes, chronic respiratory disease, other pre-existing conditions, you are more likely to die from COVID. Your chances of dying from COVID, if you have no underlying conditions, is less than 1%. Right? So I hope we all realize that. There's been a lot of fog around COVID in this country. I think the media, we can talk about that, has done a terrible job in general in telling the story of COVID. But without underlying medical conditions, your chances of dying if you contract COVID is less than 1%, which of course is immensely socially patterned, racially patterned, economically patterned in this country, which then manifested in people in particular, racial and socioeconomic groups dying from COVID. Like there's no particular mystery. No particular mystery. COVID unfolded. It was a book that was already written, and COVID just added layers of script on top of it. Death rate ratios at all ages, and in particular, what I want to show you is that this is white, blue is white, and black is gray, and Latinx is, black is orange, I'm slightly colorblind, and the gray is Latinx, but just focus on the blue and the orange. What I want to show you is that this enormous gap in death rate, particularly among younger groups, less so among older groups. Why is that? Well, among older groups, white people also start having comorbidity. While among younger groups, the burden of disease is shifted among Black Americans that have more disease earlier, which then becomes what COVID affects. And just one note about mental health from a paper that we just published that shows been about a threefold increase nationally in depression. This looks at no symptoms, mild, moderate, moderate, severe, severe. Blue is pre-COVID, the red is post-COVID. So you see pre-COVID versus post-COVID, fewer no symptoms and more mild, more moderate, severe, more severe. That's about a threefold increase in symptoms of depression post-COVID. And that is importantly, completely socially patterned. The group with more risk of depression is a low asset, high stressor group, which means people who did not have assets before COVID, as we measured, and I can get into how we measured in the study, and the people who then face stressors like unemployment during COVID. That's the group that had more depression. So I feel like I've been involved in a lot of sort of public writing about depression, trying to destigmatize depression, trying to communicate that depression is a common health condition and one that's important to recognize. Unfortunately, it almost always gets caught up in this narrative. It's like, well, it's a problem of the wealthy. It's not. It's actually not. Poor mental health is disproportionately a problem of people with fewer assets, fewer resources. It is a problem of the poor. I'm using those words intentionally just to stick it in our minds, just like everything else is. And that fundamentally we cannot overcome that unless we deal with these underlying social divides. And we are continuing to deepen these divides. I've showed some examples of that. This is about teaching, and this is pupils falling behind. And all I want to show you is that kids falling behind 6 months or more, 5 months, 4 months, etc. Kids in deprived, more deprived, least deprived schools. Kids in the least deprived schools are really not falling that far behind. My kids are not falling that far behind. Your kids are not either. It's kids in the more deprived schools who are the ones who are falling behind. So let me conclude. And I just want to conclude with a couple of slides on the role of science, because this is here at university. We had the good fortune of being invited by you to speak at a university. I live in a university. It's my intellectual home. And I do think that science has had a role to play here in how it has informed the COVID conversation and how it has privileged particular messages, particularly a message like this one. It's been a lot of COVID research. It's the steepest growing area of research for any topic ever. I think right now we're close to 9 to 10% of all papers being published are COVID-related papers, which is really quite extraordinary when you think about it. So we've been publishing a lot of papers. And we've been publishing differently, though. We've been publishing differently. This is where papers have been published 8-to-1 preprint to peer review ratio in our publication of COVID. I'm not here to bury preprints. I'm just simply raising questions. I'm actually asking ourselves to say, how is it that we have told the story of COVID? How have we told the story? And are we in scholarship and science holding ourselves accountable to telling the right story for how COVID has affected our health as a country? So let me conclude. I'll conclude with talking about the contagion next time. And I use that term self-consciously on After the Fire next time, James Baldwin's classic book of the ineluctable role of racism, personal, interpersonal, structural racism in shaping everything about life and about experience. And because fundamentally, I think it's impossible to tell the story of COVID without telling the story of the underlying divides, underlying social divides, race being a predominant factor, and underlying economic divides, which mirrors race, but also has its own total dimensions. I don't think you can tell the story of what happened with COVID without actually dwelling on these forces, without saying that the contagion next time will behave the same as this time, unless we deal with these underlying forces. We knew a pandemic was going to happen. I mean, Time Magazine serves as as mainstream as it gets. I mean, Time Magazine is not in the business of saying controversial things. And there they are 2 years ago saying, we're not ready for next pandemic, to which the answer was, yeah. But we're not ready, not just because of our underinvestment in the pandemic preparedness and the public health infrastructure, which is fundamentally what they talk about. It's because we're not ready because we allow our society to be structured in such a way as to create these health divides that then become the COVID divides that we saw now. I'm going to stop here, and I'm going to stop on this picture. This is the picture of the best soccer team in the world, which is the US Women's National Soccer Team. I'm showing a picture of soccer because it's the only sport I care about. But I'm actually showing it to end on a metaphor. I started with a story, so I want to end with a metaphor of soccer. And for those of you who don't know soccer or play soccer, and I'm sorry for you if you don't, but the way the sport is played is you have 11 people on one side, 11 on the other side, and they try to get the ball into the other person's net. And 10 of the players, these are the 10 women wearing white, they can only use their feet. Hence, it's called football, appropriately. The woman in the black can actually use her whole body, arms, legs, etc., to stop the ball from getting to the net. So if the goalkeeper, and the listener is the goalkeeper, she's very good. If the goalkeeper is like superhuman, bionic, she will not let a single ball in and you will always win. Because remember, if nobody scores against you, you can't lose, right? Now, if you don't play soccer, you might think, well, if I have the best goalkeeper in the world, I'm never going to lose, which is true, theoretically. And if you watch a professional soccer game, what you see the goalkeeper do is prowl her box, walk around from her net, and yell at her fellow players. And what she's doing in yelling at her fellow players the whole game is she's saying, keep the ball away from me. And why is she doing that? Well, because if you've ever stood under a soccer net, it's pretty big. And the best goalkeeper in the world knows that the ball's going to go by her sometime. Why am I telling you this? I'm telling you this because the goalie is medicine and healthcare, right? We want a good goalie. You want a good goalie. When I have malaria, I want to be treated for my malaria. I think you do as well. And the goalie is medicine. But you're not going to win unless you have 11 players. You're not going to win unless the other 10 players also act. Those other 10 players are gender equity, dealing with segregation, dealing with structural racism, dealing with housing, dealing with domestic violence, dealing with poverty, dealing with creating availability of nutritious food. Those are the other 10 players. And we as a country tend to think of health as being just the goalie. And the goalie is important, but it's just one of 10 players. And we have lost in COVID soccer because we have a very expensive goalie. And that goalie has been nowhere near good enough because we have not invested in the other 10 players. That's it. Thank you so much for having me. I'll stop sharing and I'd be delighted to take questions, challenges, correct me where I was wrong.
Thank you so much, Dr. Galea. You know, I've heard a lot of social determinants of health analogies, and that is by far the best analogy for social determinants of health I've ever heard. So congratulations. I'm going to remember it forever.
Please use it. Please use it.
I'm going to repeat it, but I'll attribute it to
No, it's yours. You may all have. The more people say it, the better.
I don't think I like soccer as much as you, so I can't give it that much. So at any rate, we do have a couple of questions. If folks have questions, please put them in the chat box and I'll deliver them to Dr. Galea. So the first one is from a Maxwell faculty member, Sarah Hammersma. She said, I would love to hear more about the consequences of missed screenings and other healthcare due to lockdowns. I understand some doctors made a statement of concern about, for example, extremely low rates of recent cancer diagnosis. Is this a big issue? Did we make a mistake, or is it a necessary cost of managing COVID? And I'm particularly interested in the consequences for inequality.
Yeah, it's a terrific question. I think we should all settle in and we'll discuss that for the next 2 hours because it's a great question. Let me answer it very briefly. Number one is, I think it is a concern. I think it's a valid concern. I think it's a concern in terms of we are going to see the picture emerge much more clearly about the excess deaths in COVID times, not due to COVID. And that story is going to emerge. And there's no question there's going to be inequalities on that. The second part of the question, which is in some respects super interesting, is, I apologize, I don't remember the name of the questioner, but you said, well, was this a necessary price to pay? And I suppose my answer is, I don't know. But we as a country have never discussed it. Like, we have not had a mature adult conversation around the consequences of COVID since COVID started. But these are the kind of questions that we should have been asking. Is that worth paying that price? Is the lockdown worth paying the price that we're paying? I don't know. And I realize it's a little bit anathema in public health. I'm saying that because there has been a hegemonic set of thoughts in public health that it's sort of lockdown or die. And I'm not sure that that's right. And I don't know that it's wrong. I just don't know that it's right. And I just don't think we have had the honesty to have that conversation. I think we should have that conversation. We should have had it 6 months ago. And I also, by the way, have given up that we're ever going to have that conversation with the current political structure. But be that as it may, I think the question, was it worth the price, I don't know. And I think it is important that thoughtful people interrogate whether that's worth the price.
It's always fulfilling when a researcher says, I just don't know. I think that's important for us all to hear and to acknowledge when that's the case. Katie Green asks, what do you believe we will learn from the one-time CARES UBI payments in terms of mitigating some of the economic, social, and health impacts of COVID-19? If we had continued to make those monthly payments, do you believe we could have mitigated some of the disparate disease burden?
Yeah, it's a great question. To my mind, the answer to the second question, the easy answer to the second question is absolutely yes, no question. And I say that based on the evidence about how resources ultimately become health, and absence of resources becomes absence of good health. That's number one. Now, let me talk about the sort of the first half of the question. I worry, I want to make sure that this doesn't sound in any way wrong or callous, but I actually think one of the most interesting things about the moment is there are a lot of natural experiments. We're going to have amazing data to be able to answer questions about, like, how did you called it UBI payment, the questioner, and I agree, it was essentially UBI. What impact did that have on those who got it versus those who did not get it? So stepping outside from the human pain and suffering of the moment, there is going to be a lot to learn. There are going to be a lot of interesting questions. And I think it is a privilege to be in the community of scholars who can ask those questions, because I, for one, am really looking forward to learning from a lot that has happened in the past few months.
We have a question from Janet Wilmoth, a very demographic question from a demographer. Please comment on the potential long-term health implications of COVID. How might these COVID disparities exacerbate existing age-related health disparities?
Yeah, I see no way in which they don't. I see no way in which they don't, with one exception, that one caveat to my comment, which is that fundamentally, COVID remains a fairly small proportion of deaths in this country and a disease, right? So 200,000 people die from COVID, which is terrible, but 3 million people die from any other disease in the country at any one time, about 2.9 million. So it depends if we're looking at population averages or we're looking in groups. But the social patterning is so strong that I would expect there to be age-related demographic divides that are going to deepen and continue. And not just that, I mean, that is sad, but what really breaks my heart is the trajectory, the life course trajectory that we are putting young people on, young children on, as they fall behind educationally, which by definition will mean they're going to fall behind in social, economic, and as a result, health achievement.
Indeed. Claire, one of our wonderful graduate students, asked, do you see it as reflective of the institutional structure of U.S. policymaking at the state and federal level that drives our overspending on medical care and what underinvestment in social policy? Why is the U.S. different from other countries on this front? And how would you imagine a successful policy campaign to produce a paradigm shift?
Yeah, that's a terrific question. Thank you. I suppose I've come to feel that policy and politics follows the public conversation. And to change that, we need to change the public conversation. My last book was called What We Need to Talk About When We Talk About Health. Really, essentially, the talk I gave you was my last book. And the point is, I feel like we need to change the conversation. That as long as people sitting around their dinner table think that health is caused by their doctor, we're not going to change any of this. We've done some surveys, and some people have done some surveys to say, rank these things in terms of causing your health. And people generally rank politics last in terms of as an important cause of their health. And I would argue politics is number one as a cause of your health. In fact, my last book, the first chapter, is about politics. So I think that's the conversation that needs to change. And I think we need to change the conversation. And I suppose that's why we're having this conversation. If everybody here can go and have that conversation with another 20 people, slowly the conversation will change.
Alex Punch, who is our associate director in the Learner Center, says, I've read a lot lately that our country's fee-for-service healthcare billing structure has exacerbated COVID. Do you think altering the way in which we pay for healthcare in the future could eliminate some of these disparities?
Yeah, it's a really complicated question. I think the answer is yes, but I'm giving a guarded yes because I think it's a super complicated question. I think it's not just a matter of how we pay for healthcare. I think it's also how we structure healthcare, our absence of investment in primary care. The national conversation tends to be around universal health coverage, essentially, right? And Medicare for all, not Medicare for all, which is an insurance coverage question. You ask a payment question, which I think is important, but there's also a healthcare structure question, which is where we put our resources and how we structure primary care and not primary care. So I think the whole mass of issues could improve our healthcare delivery. I don't think any one of them by itself will be sufficient.
And with the time left, I'll reserve the last question for me. You showed trends for the US and the UK, which pretty much show the same thing, right? Inequality, inequities, and COVID's impact by socioeconomic status. Are you aware of any countries that have gotten it right? Not just sort of keeping rates of COVID low, but where we don't see an SES divide, and that not just because everybody's got high rates, but that, there's more equity in the country that produces lower inequity in COVID? Or is the pattern pretty much universal everywhere in the world where it's the low SES groups that are bearing the brunt of the burden?
As far as I know, the pattern is universal, and I would expect the pattern to be universal. I think the core question, though, is how big are the gaps and how much did the gaps build on pre-existing gaps? The observation, I sometimes tell this to epidemiology students, the best documented association in all of population health science is that higher income, better health. And that's true hundreds and hundreds of years. That hasn't changed. We can talk about social structures, about flattening incomes. Those are more conceptual, political, economic questions, which I will leave aside. But then the question becomes, how steep is the slope? What's the slope if there's income and health relationship? How steep is the slope, and how bad was that to begin with? Remember the point I was making about comorbidity, right? If you don't have comorbidity, mortality rate from COVID is less than 1%. if we are then putting comorbidity all on people in a certain part of the income spectrum, we are essentially sending those people up to die when COVID happens. So that's, I think, the scale and magnitude of the problem in this country, which I think dwarfs most other countries.
And I think with that, we will go ahead and wrap it up. Thank you, Dr. Galea, so much for your wonderful presentation, and thank you all for attending this year's event. If there are additional questions that you'd like to make sure to get to Dr. Galea, just put them in the chat and we'll keep the screen open for a bit, and then we'll send them on his way later. Okay.
Thank you so much. Thank you so much for having me. Thank you, everybody.
Thank you all. Have a great evening, everybody.